All
Very
right.
well, thank you.
I've just gone through your resume. Very, very rich. It says you have specialist interest in treating intestinal and, of course, pediatric, as well as breast, gynecologists, and all sorts of cancers, so to say. So it means your experience is really, really needed, as we're going to be talking about this morning. So how was the journey here, doctor?
Oh, it was smooth. It was straightforward. I spent about 10 minutes en route, and I got here in time.
That means we have
ahead of time, actually.
That's true. You've been here for quite a while.
Yes.
It means we have fewer vehicles on the road. That's what it means.
Yes, that's what it means.
All right. So, doctor, before we even focus on childhood cancers, let's just refresh a bit and talk to our listeners this morning. What kind of an ailment is cancer?
Okay. Cancer is, in the most simplistic manner put, it's the uncontrolled proliferation of cells. So the word uncontrolled is important because cells usually proliferate, and that's how you grow and develop.
Right.
But when the body can't control this growth anymore, the cells just go out of order and they grow and they cause their attendant effects depending on where they are growing.
So at that stage, it's now become an abnormal situation.
Well, it's a spectrum. Before it develops to cancer, it goes along a spectrum. There will be what you call benign growths, where you have these growths, but they are not cancerous, yes. But the three qualities that make a growth cancerous would be that it invades the local area, it metastasizes, which means it can break off into chunks and go to distant locations, and that it recurs. Even after you remove it, it has a tendency to recur again. So most normal benign growths, when you take them off, like you have a normal breast lump, you take it off and it doesn't grow back again. But what cancer has that kind of like distinguishes it from the benign growths is these three things I just mentioned.
Right. So what causes cancer? Because a lot of times we ask that question and we never seem to get the right answer. So what is the cause of cancer?
Oh, it's multifactorial. It's really, so many things you can point at. There are acquired factors and there are also inherited factors. So it now depends on the kind of cancer you're talking about. Some cancers are as a result of environmental exposure, things you expose yourself to, like cigarette smoking, lifestyle. Then some cancers, you can't help them because they're already inherited. Right. Then some of them happen at the genic level, which is mutational. So it's multifactorial.
Yeah, but sometimes, I know some of you doctors do say it cannot really be explained, the causes of all these cells mutating and growing uncontrolled. Is that the case sometimes?
So cancer research is one of the most robust fields of research because there's so much we don't know about the cells. I mean, looking at the genic level and looking at the tissue level, you find out that there's so much fine interplay between growth factors, growing, and cellular responses. So it kind of makes it difficult to point out a particular thing that makes a cell suddenly decide that, it's not going to toe the line anymore. It's not going to follow the defined order. And these things happen largely as a result of a lot of insults, which we're still understanding.
Right. So sometimes, let's put both of us together in a room now. You smoke and I'm smoking. Both of us are smoking. How come sometimes I might be affected and you are not affected? So in that case, is cancer turning to be like a juju kind of thing or what?
Well, it's, like I said, an interplay of so many factors. You have so many people who've smoked all their lives and they don't come down with cancer. Then you have people that we call never smokers. They've never smoked. And you see them coming down with small cell lung cancer. And even as we progress and advance as a race, the epidemiology of cancers are changing. If you looked so many years ago, you would find out that the majority of people who had non-small cell lung cancer were men. But as time goes by, you find out that the epidemiology is changing. A lot more women are coming down with non-small cell lung cancer, even the never smokers. So it's very complex and it's rapidly changing the same way we're changing as a species.
All right. So what are the different types of cancers that we have?
Oh, there's so many. So I like to summarize it so we don't go naming all the organs in the body. I tell people what, summarizes it and makes it easy for us to move on. You can have cancer in almost every cell of the body except the hair and the enamel of the teeth and the nails of the fingers.
Why are those places unique that cancer can't affect them?
So those places are unique because they are hyperkeratinized in that they don't have very viable tissues in them, but they have keratin, and hyperkeratinized means that the viability of those cells makes it such that you can't have cancer thrive in those areas. And there are so many other factors that are linked with that, but largely the hair, the enamel, and the nails.
Right. So apart from these three, all other organs in the body can be affected.
A lot of all the other organs in the body are largely affected.
The skin?
Some rarely, of course, the skin, definitely. So the skin is one very special area because there's a very stark geographical variation in skin cancers. You don't find them very much in some areas, and you find them in some areas because UV radiation has been implicated in this. And also the variation of melaninization of the skin also makes it a distinct category where you have geographical variation.
So these different types, they occur and they exist. How common is cancer globally? And of course, if you narrow it down to Nigeria, doctor, how common is cancer?
Oh, it's very common. I think we spoke about this at my last discussion with you, where we talked about how cancer is moving along the trajectory from, I think, 15, 20 years ago, it was fourth most common non-communicable disease. Now it's at second, and it's only behind cardiovascular diseases, which will be the strokes, heart attacks, cardiac arrests, and the heart failure.
Wow.
So it's moving along really fast, and I think it's responding to our lifestyle changes and our increased ability to diagnose these conditions. So we know a lot more than we knew about it in the 70s.
What about in Nigeria? Is it very common?
So, it is. And trust me, it's being underdiagnosed. So we're increasing our diagnostic capabilities in Nigeria, and things which we hitherto referred to as arrows from the village and, enemies and all those things you see that are left in the hands of charlatans.
Right.
We've been able to demystify them and understand that these were undiagnosed malignancies. So as much as we are moving along, we want to ensure that our diagnostic capability is top-notch. Then we leave the treatment headaches for when we get the diagnosis. But a lot of it is really underdiagnosed.
Yeah, but when we have doctors like you, a lot of times, doctors do not believe in all those kind of arrow things. But arrows, do they exist really?
You're dragging me out into the wild here. I won't speak about things I don't know so much about.
All right. I know doctors don't want to go into that realm at all. But cancers, are they curable?
Yes, to a large extent they are, but there are so many clauses and subtexts to that. When you talk about curing a cancer, what you essentially mean is that it's not going to recur and it's going to remain in complete remission for at least 10 years. So it's very complex, but you can cure a cancer, and you can mainly cure it when you discover it at the early stages. And this is why we talked about diagnosis. We need to find it when it's early. You can't come with a stage 4 cancer and completely expect a cure. So we use our language very carefully in oncology. We use the words cure, manage, and palliate for different stages of cancer. So when a doctor is using the word cure, he definitely knows that with the implementation of all the modalities of treatment, this cancer will not come back again, and you can go do your Thanksgiving in church.
Right.
But when a doctor tells you can manage the condition, they're being honest and realistic with you in that we can make sure it doesn't come back for a period of time, but the chances of it coming back are really, really large.
You mean it?
Yes.
Because I've seen people who have survived this 10 years, 15 years, and they're still very strong in town.
Oh, yes. So there's so much to talk about when you talk about survival. You can talk about the nature of the cancer they had. Was it a very aggressive variant?
Oh.
You also talk about their risk categories. So some people fall into very high-risk groups, which kind of reduces their long-term survival chances. Some people have less aggressive types.
So you mean this cancer, they come in different characteristics, right? So some are very aggressive.
Yes, cancer is like a life form of itself. It's like an alien life form. So it adapts, it changes, it comes in shades and spectra.
Okay then. So this program is going to be, we did say that we're going to be focusing on childhood cancer. So doctor, we've heard of breast cancer, we've heard of prostate, cervical, and all of that. Where are these childhood cancers coming from? Talk to me first.
Oh, yes.
What are childhood cancers?
So childhood cancers, this specialty is very morbid because you're dealing with children, and, there's a lot of emotional component to it. So we have to talk about what the child is in terms of oncology.
Okay.
So we usually do from infancy to 19. But even within that category, you still subdivide it because there's so many components that are to be considered. So 0 to 19, which is infancy to 19, then you further divide it infancy to 14 and 15 to 19. Because those at 15 to 19 tend to fall into another overlap of age categorization. Those are the adults and the adolescents and young adults. They also fall into the category of the 19 to 40s, which is a different consideration in the realm of oncology. So 0 to 14 and 15 to 19 are the subcategories of childhood. So those will be the prepubescent and the adolescents. So adolescents are those who have attained puberty, yes, but they're still undergoing some developmental changes. And the prepubescent are those who haven't had the impact of hormonal changes on them yet. So yes, that is childhood.
So they come down with cancer as well?
Oh, yes.
Because before now, what we're used to is that cancers are more for those that are a little bit advanced in age, probably those within the middle ages. And in the past, they always tell us once you are 40 and above, you can begin to do this test, do that test, just to ensure that you are free from cancer. So you're telling me now that ages 0 to 14 or even to 19 are also coming down with cancer?
Oh, yes, they are. And it's a completely different realm in terms of all your considerations, your treatment, and even your diagnosis, because you can't expect something to manifest the same way it would in a 19-year-old as it would in a 3-year-old. So there's some particular cancers that usually are issues in that age category. Let's talk about the 0 to 14, for example. You have leukemias as the mainstay of incidents. There you have leukemias, you have brain and nervous system tumors. Wow. You also have lymphomas and solid tumors, as against perhaps the 40-year-old man who would be contending with perhaps colorectal cancers, lung cancers, and other cancers of adult varieties. So in this age category, we know that these are the distinct categories of cancers that they tend to have. Then in the 15 to 19, you see a slight shift, although it maintains a bit of the incidence of the younger category, but there are some additions. You can now have testicular cancers and thyroid cancers. But if you look at it holistically, these leukemias, lymphomas, and nervous system tumors tend to be the mainstay of diagnosis in them.
And the same cause, is it the same cause that we've identified earlier on? Okay,
so another reason why we distinguish these categories is that the younger categories, a lot isn't known about the causes of them because they are quite rare. A lot isn't known about the causes because they are quite rare. And you find that it's easier to do a diagnosis in a 40-year-old who you can interact with as against a 2-year-old who can barely talk. So you don't really understand so much about the clinical progression of this disease because the best you can get is information from the parent or the caregiver. While in a 40-year-old, he can tell you, oh, I used to smoke a lot, or I used to drink a lot, or I was exposed to this at work. So a lot of research is being done, but you have to have a robust study sample to actually put out anything that is causal. So what we have at best is a lot of correlations, but causality is being built up as more cases are being diagnosed. And like I said, it's quite rare, so it makes it hard to study it.
Dr. Chidiebere, I know you've traveled widely. You must have gone to so many countries in the world. And what you are talking to us this morning is looking at a diagnosis that you must have seen in Australia or perhaps in the United States of America, where you practiced at one point or the other. So talk to me. At NSIA-LUTH Cancer Center, have you seen children coming down with cancer?
Okay, so I've traveled a couple of countries, but I haven't practiced anywhere outside Nigeria. I just wanted to put that out. So at NSIA-LUTH Cancer Center, we focus a lot on pediatric radiation oncology, and we're blessed to be in such a multidisciplinary environment like the Lagos University Teaching Hospital, where we have so many specialists. We also deal with the pediatricians and all the subspecialties in pediatrics. So we bring on board the radiation expertise and the palliation of chronic diseases, while the pediatricians help us with diagnosis and management of the patients. So it's important to understand that, yes, these cases, though they are rare, we are seeing a lot of them at our center.
You mean it?
Perhaps because our center is one of the very few centers where we can have referrals to, because there are not so many centers in the country that have the capacity to do that. But we are seeing them. First, the last time I checked, from the beginning of 2023 to I think it was September 2023, we had about 72 cases of radiation for patients with pediatric cancer. So you would also have to know that a lot of them, all of them don't need radiation. I'm just talking about those that needed radiation. It's 72. So it's a large number.
So it means that the numbers are going to be higher in terms of infection.
In terms of what?
in terms of those that are affected by cancer.
I thought you said infection. In terms of those affected, yes, right. we have them coming a lot of the time. We do.
Wow. This is revealing. So childhood cancers are on the increase. That's what it means.
Yes, they are on the increase in terms of diagnosis. We are just starting to diagnose them more. And I have to talk about health education a lot here, because the responsibility of care for a child doesn't fall on the child, it's the parent.
Yeah, so we'll come to that even as the program moves on. But in terms of gender bias, or how would you put it now, for childhood cancers, do we have more in male or females, or how does it go?
Okay, so for the solid tumors, that's where you see a slight gender disparity. Sometimes in male to female ratio, you might see 1.3:1. You might see 1.5:1 among the renal cancers in children. That's the nephroblastoma. Mm-hmm. You can also see that in neuroblastoma, but it's not so wide and distinct as you would have in the adults, because in adults, those are people who have gone through hormonal changes. That's where you now see the disparity. In the younger age categories, it's quite close, and even if there's a distinction, it's quite small, but you have a preponderance that is almost the same most of the time.
All right, Lagos Traffic Radio 96.1 FM. Lots of knowledge, lots of things this morning, and I'm speaking with someone who's a specialist in this area. All right, he's a consultant, clinical and radiation oncologist with the NSIA-LUTH Cancer Center. Dr. Chidiebere Agbakwuru is my guest on the program this morning. Getting back to the roads, we did hear from Adile earlier on that there's a breakdown of a truck, another articulated vehicle that's on the main carriageway at Idiroko. It's affecting your movement, backlogging traffic towards Maryland right now. So you need to watch out for that as you drive through that corridor. But at the rear, coming in from the Ojota end, is still looking good as well. Quickly taking you through the Ejigbo corridor, vehicular movement from Pako Okiafa up to Jakonde Gate, proceeding towards NNPC intersection, looking very, very good for now. Movement from Jakonde Gate as well as Ijegun heading towards Okiafa up to Pako is at a steady rate at the moment. We have some uneven portions of the road there, coupled with alternation at the gate that will slow you down a bit, but nothing to worry. In and out of Old Garage, connecting Ikotun intersection, heading towards Council and Ojodo, moving at a slow pace as well. But beyond that point, it's a smooth ride from Synagogue, Ilewe, Sele, Igbe, Power Line, Iyano Ejigbo, and of course the NNPC junction, all looking pretty good this beautiful Friday morning. Appreciable movement in and out of Mobostic, proceeding towards Keno, looking good. And I can tell you all that corridor, traffic managers on ground trying to manage the situation as well. Adele, what's happening to the impediment on Eco Bridge? How far have we gone with that? I hope it's been taken off because this is over 2 hours now since we recorded our breakdown within that corridor. Okay, then, so as the program moves on to, if you have any question for my guest who's very, very vast in this area, you can connect with us and let's see how he can break it down for us all. Okay, so still dwelling on these childhood cancers, you said the NSIA, they have been able to record so many, and of course in terms of bringing intervention, you guys have been using technology to also check that. But talk to me in terms of care. You were trying to make reference to care for childhood cancer, how we can care for them. What's the best way to care for children that are coming down with cancer?
Okay, the best way to care for them is to diagnose them early. I always say that it's important to diagnose early. That's the very first point.
Okay, so before we even talk about diagnosis now, so what are the symptoms? What are the things that one would see that would indicate that this child might be coming down with some form of cancer?
Okay, there's so many of them. The first of all is no symptoms. Sometimes you might not really see anything. You might just find it incidentally when maybe doing a dental exam or something else. For some other reason, you find it, as with all cancers. Then you find that you see commonplace things, but it takes the attention of a dutiful parent to note these things. For example, you have a child telling you they have headaches. And, it's not something that is very common in children to have headaches all the time. Or you have a child who suddenly stops eating. You have a child who's losing weight at, very alarming proportions. You have a child who is suddenly bruising or bleeding. You have a child who suddenly starts to, maybe their teacher tells you they're paying less attention in class and they're grades are dropping and you notice some cognitive deficits in the child. You can also have a child with an enlarged abdomen. You can have, there's so many things. You can have a child with a white spot in their eye. It just depends on the particular cancer that is involved. Then you find that this is what is causing it. Also, repeated hospital visits should be looked into. A child is being treated for infections all the time. It's not supposed to be that way because children's immunity is quite robust after a particular age.
Yeah, but you know, a lot of times people say these days, due to the harsh weather and all of that, and anytime the child comes down with one form of, temperature or something, they have to take the child to the hospital. So are you saying this could be some signs?
Well, there's a difference between actual recurrent infections and seasonal illnesses. So some children have seasonal illnesses, which are probably due to allergies or some viral flu that comes with a change in the weather. Okay. But this is different from a child who keeps coming down with chest infections, a child who is coming down with repeated urinary tract infections, and the doctor has treated the first time and they come back a couple of months later, they've treated again. So that has to raise the doctor's eyebrow to see, okay, why is this child having this particular pattern of repeated infections?
Right.
Yeah.
Okay, so that could be... Now, apart from that, any other kind of symptoms that one would notice?
Oh, yeah, there's like so many symptoms and we could go on all day, but there's a very nice acronym that people would do well to know. You don't need to cram it, but it's literally like child cancer. So there's constant headaches, there's so many of them. There's intermittent fevers, there's low weight, there's distraction in class, there's things that you should look out for, and it will tell you that something is wrong here, something is not really going on well.
Right.
So there's so many of them.
I can see you're trying to break it down from the childhood as an acronym.
Yeah.
Okay, the Lagos Traffic Radio 96.1 FM. I have a specialist in the building, and we're talking childhood cancers. He's been able to let us know what they are and the nature of this kind of cancers, and of course what can be done. Now, same for the elderly, Dr. Agbakwuru. It's almost the same kind of strain that it's curable or treatable or manageable for children.
So fun statistic, in the 1970s, of course I'm talking about statistics in the Western world. We don't really have our statistics put together, but in a couple of years we will. So in the 1970s, let's say mid-1970s, the mortality rate for non-Hodgkin's lymphoma was really high as about 80-something%. Now it's about 42% in terms of how many people, despite their stages, that actually pass from this. So we talk about these things and we don't really know what the numbers are saying. Currently, in high-income countries, the survival rate for childhood cancers is above 80% over 5 years, while in low and middle-income countries, the survival rate is less than 30%. Despite the stage they present in or despite the care they've received, it's still really low. So we can tell that our counterparts in other developed countries are completely having a handle on this condition. If you look at some particular cancers, their survival rates, because we just looked at all the cancers put together, the really morbid ones and the less aggressive ones. But if you look at some cancers like Wilms tumor, you'll find out that the survival rates are as high as 92 to 96% in advanced countries.
Wow.
While in Nigeria, I'm not sure we want to talk about what the numbers are.
Okay, all right. I'm sure as this go by, we'll definitely get better survival rates. All right, so flash update coming in from the control room. The impediment on the Eko Bridge inwards Akpongpong is off the road right now. So that's good news for those of you making use of that corridor from Ojuelegba connecting, talking about Funshaw Williams to Eko Bridge. It's a much better drive right now. Okay, then. So let's see if we can expand the discourse beyond the studios to have your input as well. We're talking childhood cancers. Are you actually marveled from what doctor has said this morning? And I just see some areas of concern for you from the explanation that he has given. Of course, he has taken us to the classroom on how these kind of childhood cancers, how they really work out. But if you're still marveled or perhaps you're still astonished as to cancers or the presence of cancers in our children, you can feel free to connect with us this morning. 08099120777 and 09153877127. Okay, that's 09153877127. 08033877127. Those are the numbers that you can connect with us. We're talking cancers in our children, and he has even, classified the age categories that we can put them into, either 0 to 14 or perhaps from 15 to 19 as well. Okay, so share your thoughts with us. I'm having some messages that are coming in for you, Doc. This one says, "Good morning, Doc." Okay, let's take this call. Hello there. Good morning.
Good morning, sir.
Good morning.
Morning, sir. My name is Shegun Adebi.
Hey, Shegun Adebi. How are you doing, sir?
I'm fine. Are you too?
Very good too. I have a doctor here.
Doctor in the house. Good morning, sir.
Good morning.
Morning, sir. Please, I just want to ask a child that is complaining of a repeated headache, what kind of test can he or she do to know his or status as regards the topic you are discussing this morning? Thank you, sir.
Okay, all right. Thank you very much, Shegun Adebi. Okay, so he says a child who is complaining of constant headaches, are there tests that he can do, especially considering what you just said right now, that can reveal the true status of his or her health?
Okay, I thought we would take a couple of questions and I'll just answer them.
Okay, good. Okay, let's do that. 08099120777. You can also bring in your questions. I said, this one says, "Good morning, Doc. Please, what factors contribute to the rising incidence of childhood cancers in Nigeria?" What factors contribute to the rising incidence of childhood cancers in Nigeria? Sheriff Arabambi is sending that one in. Another one here says, "What specific initiatives does NSIA-LUTH Cancer Center have in place to support childhood cancer treatment?" Eniola from Ojota. Okay, so let's address it three.
Okay, just hold on 1 second.
Okay, all right. Meanwhile, if you want to join the conversation, feel free. 09153877127. 09153877127.
Okay, the first question is, the gentleman said...
That's Shegun Adebi.
Yes, Mr. Adebi said he talked about headaches in a child.
Yes, recurrent.
And what we need to do for that child. So first of all, that child needs to be seen by a competent clinician, that is a doctor, who would assess the progression of these headaches, when they started, the pattern of these headaches, and what the headaches manifest with. Do they manifest with vomiting? Do they manifest after any exercise or play? Was there any traumatic event to this child? When the clinician looks at those things, then they do an examination, which is very crucial. They do an examination to see if there are any deficits in this child's normal physiognomy. They check if the child has good neurological function, they check vision, they check all the things that are associated with a headache. And afterwards, if the history adds up to the examination, then the clinician would ask for an investigation.
Dr. Chidiebere, there's no one size fits all for cancer tests, right?
No, there's never only one size fits all. Before you do some tests, you should have some justification, because some tests in and of themselves, they don't necessarily need to be done unless you have justification for them, especially those that make use of ionizing radiation like CT scans. So you could probably say, I've looked at this child has had headaches for 3 months, and the headaches usually come with some vomiting, and when I did a neurological examination, this child was having upper motor neuron symptoms.
Right. Because
of that, I want to do a CT scan.
So leukemia, for instance, now, what kind of tests will reveal that someone is coming down with this kind of cancer?
Okay, so leukemia, you have a clinical pattern a lot of the time. Leukemia is essentially a cancer of the bone marrow. So you have the precursor blood cells not maturing, and so they are not effective. So what you now notice is, we talked about recurrent infections earlier. I told you about how that is something to be worried about, especially when a child can't fight infections. And when you now notice these recurrent infections, the first thing you have to do as a clinician is to do a full blood count. When you do a full blood count, you would see abnormal counts, which will make you do a peripheral blood smear, perhaps. You could do a peripheral blood smear. That further justifies your line of thought.
Right.
Then you could do something like a bone marrow biopsy. All
right, let's quickly respond to Sheriff Arabambi's question. What factors contribute to rising incidence of childhood cancers in Nigeria?
Okay, like I said, childhood cancers are so rare and they are poorly understood. But we know for sure that 8 to 10% of them are as a result of inherited mutations. For example, a mother with an abnormal gene. There's a gene called the RB gene. A mother with a faulty RB gene who passes it on to the child would predispose that child to having a cancer of the eye. Then there are some other mutations that are not inherited, which might happen at some point during the embryonic development of the child. Let's take, for example, there are some things that just happen because of, they just happen as a result of some biologic malformations, not for the fault of the mother, not for the fault of the father or the child.
Right.
And you suddenly have a chromosomal abnormality, like, say, trisomy 23, which is trisomy 21, which is Down syndrome, which means that there is a defective allocation of the numbers of chromosomes. Such children are naturally predisposed to leukemias. So you have to look at what happens in utero and what happens as a result of mutations in the child. So it's largely to mutations and inherited syndromes.
Right.
We haven't been able to allocate any environmental exposures as causes for these cancers.
Okay, then. So there's so many questions that are pouring in for you. Before you answer the other one, which is on NSIA, the interventions they are putting in place. This one says, good morning, Traffic Radio. How often should one go for tests yearly, done before diagnosis? Okay, I do not know. But Shegun is sending this one in. It says, good morning, Traffic Radio. How often should one go for tests yearly, done before diagnosis? Okay. Shegun, send that one in.
Okay, so let me answer the third question. What specific measures has the NSIA-LUTH put in place? So a lot of measures. First of all, we have a functioning pediatric oncology unit, which means that we have the full complement of specialists that are required to make such a unit functional.
Okay.
We have pediatric radiation oncologists. We have the pediatric radiation therapy radiographers. We have physicists who are trained and experienced in planning pediatric cases. We have anesthesiologists who come to help us give sedation if and when required. And we also have the buy-in of the pediatric team in the Lagos University Teaching Hospital. So we have a very fine multidisciplinary team that helps us to diagnose, treat, and palliate these cancers. Also, we have a fund for patients who can't afford their care. Of course, it's limited. Of course, it's limited in terms of the people that need access to that fund are like 1,000 times more than what is available in the fund. But we have a fund for people who don't have the access to funds.
How
to pay for that.
How big is the NSIA-LUTH Center?
Oh, it's quite big. It's are you talking about
bed capacity?
So the NSIA-LUTH Cancer Center uses a ward beside it called the Alima Ata ward, which was an endowment by a private individual. Massive facility. It's quite big. It has about 4 floors. It doesn't come to mind immediately how many beds are there, but it's quite big and modern.
Okay, let me see if we can just run through some of these messages that are coming in. 08099120777. This one says, cancer treatment is often expensive. Are there any governmental or NGO funded programs that provide financial assistance for childhood cancer treatment? Thank you. You didn't put your name, by the way. This one says, good morning, Victor. How can government policies be improved upon? Government policies be improved. Okay, let me try and see if I can get this. It says, how can government policies be improved to make cancer treatment more affordable and accessible? Ife from Magodo is sending that one in. This one says, hi, Victor, and the doc in the building. It says, are there national cancer registries? Okay, sorry, registries.
Yes.
Or data systems tracking childhood cancers in Nigeria to inform policy making. I didn't put your name, by the way. And this one says, good morning, TJIF. It says, what are the long-term follow-ups and survivorship care options that are available for children who have successfully completed cancer treatment? Michael or Loco is sending that one in. So lots of questions are coming.
There's a lot in there.
Yeah, but time really is not really our friend, really. But doctor, people can survive these cancers, right?
Yes.
These children can survive, right?
Yes, we talked about really high survival numbers in other countries. So why can't we do the same? 96% is something to be very proud of for the West. in terms of Wilms tumor and neuroblastoma.
Right.
So we should be able to achieve and attain that.
So which is most common right now for the ones you've seen in Nigeria for childhood cancers? Which of them is most common?
Leukemia. So
wow.
You have to look at the age categories, but leukemia largely is very, very common. You have the central nervous system tumors, you have brain tumors, you have lymphomas, and then you have the solid ones. That's the ranking.
Right.
For
any government interventions yet for childhood cancers?
Oh yeah, the gentleman asked if there were government or NGO. I can't speak to government interventions because in terms of endowment for treatment, is that what you're talking about?
Mm-hmm.
Not that I know of. I mean, the National Health Insurance Scheme pretty much is skeletal, so we probably have to look at private health insurance companies. And there are a lot of NGOs. There's the Dorcas Cancer Foundation, which helps patients to pay for their treatment. But how much can one foundation or two or three do for the numbers that actually need this help? There was the other gentleman who talked about government policies.
Right.
I'm not a policymaker, but I can tell you that it's actually quite simple. It starts at actually increasing the budget for health and making sure that there are no leakages, and these funds actually are appropriated to where they should be, used. It's a bit simple.
So for those who are listening to us right now, NSIA-LUTH Cancer Center, most of the time people refer people there. Is that correct? So
It's a referral center, yes.
So can I just walk in there on my own to say, look, these are the kind of signs, the symptoms I'm feeling. I need a test, or I need a diagnosis on cancer. Is it possible?
Oh yes. Ideally, we should have our patients coming based on referrals, but we found out that the Nigerian situation is not the ideal situation, so we don't turn people back. But we also have a cancer prevention program, which I also am grateful to be a part of, and it helps us to look at people who are worried about their cancer risk based on their family history, based on their relatives, based on their lifestyle. We're able to stratify them, put them in risk categories, and screen them effectively. That's really important. They say there's no thanks for preventive medicine, and it's true, but we are actually focusing largely on that, and we've been doing so for the past 2 years to reduce the risk of people in Nigeria before they even come down with these cancers.
All right, we have to really pack our bags after the studio right now.
All
So,
right.
Doctor, what's your parting thoughts to our listeners this morning?
My parting thoughts would be, if you're going to the hospital for one thing and you're going over and over again, you should probably seek care at a higher center. It's just the only thing I can say.
All right, then. So I must say a very big thank you to you for making it through to the studio this morning. This has been so engaging that I feel like this should continue from time to time. But, Doctor, we have to go. Thank you so much for being here.
Okay, thank you, my brother. Thank you, Lagos.
Okay, then. So what we have done this morning is just to let you know that apart from what you've been hearing out there, we're having some increased cases of childhood cancers. And the doctor has taken us to the classroom on how it all works. So let's see how we can stem the tide of all this kind of cancer so that Nigeria will be much better for it. Dr. Chidiebere Agbakwuru has been my... Agbakwuru, yes, he has been my guest, and he's a consultant clinical and radiation oncologist with the NSIA-LUTH Cancer Center. Dayo Anthony has produced the program this morning. Maximum thanks to Unwara Moloku. He is an advocate in this regard, and that's why he's always trying to ensure that we get the best of information. So I say a big thank you to you, Onora Moloku, for bringing this kind of information. Our social media team, Okpayemi Shodunke, and of course, Afe John, we do appreciate you. Taya Akonle is the executive producer. My name is Victor Oteri. I'll be back.